Next is the membranous nephropathy. So for membranous nephropathy, I have this really cool mnemonic. I am a proud member of Spike and Dome Club, S&D Club. So it's basically, so with member, just remember it's membranous nephropathy, right? But let's start with the first letter, I, for idiopathic, or you can just think of infections, right? So there can be infections that include hepatitis B, C, and then syphilis. Then we have the AM, so make the M capital, and then M stands for the medications, so the drugs that are involved in membranous nephropathy. That's NSAIDs, penicillamine, and gold. Then we have P, proud. So for P, just remember the primary cause of membranous nephropathy, which is a phospholipase A2 receptor antibodies that basically causes the membranous nephropathy. And then remember, I just told you membranous nephropathy, spike and dome club is basically spike and dome appearance on the electron microscopy. Okay, so it's it has immune complex deposition as well. There will be diffuse capillary and glomerulobasement membrane thickening, but I don't think so you need to remember all of this, but like for diagnosis purposes you can just go through with this. Afterwards, I think we have amyloidosis and diabetic glomerulonephropathy left. So it's pretty simple. For amyloidosis, it can be simply with age or because of like prolonged dialysis. And one thing that I think you all will be well versed with is that on Congo red stain you will have apple green birefringence, and that's basically the amyloid deposition. I don't think so it's important for you guys, but there is like subtypes of amyloidosis. It can be AL, AA, and then there's another one with beta 2 microglobulin, but you really don't need to learn all of that. So AL is basically positive for lambda or kappa light chains, and AA is the one for AA protein. You really don't need to learn this. Just remember on Congo red stain there will be apple green birefringence, and the one that your past knowledge will be able to help you with the diagnosis of amyloidosis. And honestly, what's really has helped me is that normally when you really can't reach a diagnosis, it's amyloidosis for some reason. For diabetic glomerulonephropathy, so we know that in diabetes there is non-enzymatic glycation, right? So the same happens over here. There is glycation of the basement membrane efferent arteriole, right? So efferent, this is your glomerulus, and then efferent. So when there is glycation over here, there will be vasoconstriction, right? So because of that, there will be increased cellular stress on the glomerular basement membrane, which will lead to the mesangial proliferation. And then the mesangial proliferation, then of course when it's the mesangium over here is proliferating, the glomerular basement membrane generally tends to hypertrophy and then creates spaces for proteinuria. So I think it's very everyone knows that proteinuria is a marker for, like, you can look for albuminuria or proteinuria in a diabetic patient and see how if he's like moving towards ESRD or not. Basically the status of like his kidney functions, like diabetic nephropathy or diabetes ultimately leads to end-stage renal disease. So that's what I'm trying to say over here. ACE inhibitors and ARBs are renoprotective. I think this is pretty easy to remember. Other than that, you just need to know that because of the mesangial expansion, there will be the basement membrane will thicken, and then it will cause glomerulosclerosis, which is basically Kimmel-Steen-Wilson lesions, because we don't get like images in the medicine paper. So I don't think so this is important, but you can just learn it. Yeah, that's pretty much it. This is all for nephrotic and nephritic syndrome.